Hello, and how are you? Welcome to the session pertaining lung cancer, focusing on causes, manifestation, and diagnosis. My name is Winnie Barawa. Kindly remember to subscribe if you've not done that, and give us a comment or a like as we continue with this lesson. This is a series that we are doing pertaining lung cancer, and we are exploring different parts. We've done the first video that works on classification of the lung cancer. If you've not checked on it, kindly check on the playlist on respiratory diseases or down below, it's there, and catch up with what we discussed there. So let's begin. So lung cancer can be caused or be risked by various factors, and part of it is gender. So with gender, we're being told that lung cancer is common in men compared to women. And also lung cancer being explains that with this gender issue, it's related more genetically as opposed to any other related facts, but basically gender has a big association, or it's a risk factor to the diagnosis of either having cancer of the lungs or not. Then you have radiation exposure, and this is simply means exposed to materials that have risks to cancer. For example, ultraviolet rays or X-rays or radiation rays, radons, and such products that can expose us to cancer or abnormal division of the cells. We have smoking history, and with smoking, the products can be different, the amount can be different. However, we're being told that smoking is one of the leading cause of lung cancer. So which factors of smoking contributes largely to this risk factor of smoking is that we have age of smoking onset, that if the client has a longer exposed period of smoking, for instance, years and years of smoking, there's an increased risk of contacting or getting diagnosed with lung cancer. We also have the amount smoked. Active smokers are people who are directly involved in the activity of smoking, while passive smokers, these are people who live in an environment of people who smoke, or rather they're exposed to the smoke in this particular case. So active smokers have an increased risk of almost 85 to 87% chances of contacting lung cancer, while passive smokers are also not left out, but their prevalence is a bit low, that is about 3 to 5%. But doesn't mean because you don't smoke, you will not get lung cancer. There is a chance based on how exposed you are into the smoking behavior. The gender of smokers, and again here we repeat, men are more common getting lung cancer compared to women. I think also smoking could be one of the reasons. Maybe more men participate in smoking as opposed to women. We also have products smoked, and this could be smoking of cigarettes, smoking of marijuana, smoking of any other artificial products. Like the smoke contained into our lungs doesn't have to always be cigarette, although cigarette is one of the most common reasons. And also the depth of inhalation. How deeply you take in the components can be a risk factor for the lung cancers. But again, we have genetic predisposition. And with genetic predisposition, this explains that in a family where there is history of lung cancer, then there's also a predisposition for other family members to be at risk of getting lung cancer diagnosis. So familial history, which is engaged with lung cancer diagnosis, can also be at risk. So we have diet, whereby we talk about excess intakes of other diets like proteins and such can increase the risk of extreme of lung cancer prognosis. But now with the low fruit diet and low vegetable diets actually increases more cancer risks as opposed to others. Then familial history, which is linked to genetics. And with genetics simply means if there's traces of lung cancer markers in a family history, then other members of that family can also get the diagnosis. And the last part of risk factor is environmental exposures or occupational exposures, where clients or the patient is exposed to factors like asbestos, radons, and passive smoking. These could be risks that can stimulate abnormal growth in our lungs, causing to lung cancer. So let's see, how does the lung cancer occur? What is the pathophysiology of lung cancer? So this will explain how the abnormal processes occur or how the steps start. And the first step in the pathophysiology of lung cancer is where we say that the carcinogens, and by carcinogens here we mean the factors that can predispose one to developing lung cancer, such as smoking or occupational agents, bind into our cell DNAs and cause damage to these cells. So when these carcinogens attach to the cell DNA and cause damages to our cell structures, then we can have cellular changes that can occur to these cells and stimulate abnormal cell growth. So the first part is carcinogens attaching to our cell DNA and damaging it, and as a result, stimulate cellular changes that can stimulate abnormal cell growth. So the abnormal cell growth now causes malignant changes of the pulmonary epithelial cells in our lungs, and so these abnormal or malignant changes start to occur. The next step is the abnormal cell growth leads to this malignancy or leads to the cancer status, and the cells keep on growing and they start covering structures of our lung. So they can start covering the bronchus or head to the lobes of the lungs. So with this happening, the abnormal division of cells, the infiltration of hyperplasia, the case of dysplasia, and even carcinoma in situ coming in, we are being told that these processes stimulate a change we call inflammation. And inflammation in our respiratory system is indicated by hypersecretion of mucus, bronchospasms, and even constrictions of our airways in these respiratory changes. So inflammation basically causes changes in our status of structures in the lungs and in the airways, whereby we have hypersecretions of mucus or hypersecretions of fluids in the airways. We end up with bronchospasms, and with bronchospasms, we have the airways constriction and reducing in diameter, but also there's bronchoedema, where they swell, and this leads to further blockage of these airways. But remember, this is a cancer process, and the main parts that is happening here is we have the cells abnormally dividing, causing malignant status, and they start depositing tumors that will be growing and covering our bronchus and also the lobes. The other bit now is we end up forming the lesions in the lung tissues, in the bronchus, bronchioles, and even the alveoli. And this cancer therefore finds a way into implanting itself, causing the stage we are calling carcinoma in situ. So the pathophysiology can basically be summarized where the first stage is exposure of the carcinogens to the cell DNA, damaging these cells, causing abnormal cell growth that ends up as malignant, and these cells keep on growing and entering the lobes and the bronchioles, causing inflammation that causes bronchospasms, hypersecretions of fluids, and bronchial edema. And then we have lesions forming, being attached to the lung tissues, bronchioles all the way to the alveoli. And the cancer finds itself into implanting itself, calling it now carcinoma in situ. And then now the other bit is about the signs and symptoms. So lung cancer symptoms can either be viewed as localized symptoms, whereby these symptoms are directly involving the lung or directly part of the lungs, or we can have generalized symptoms where the symptoms are involving other parts of the body. In cases where the symptoms are directly involving the lungs, these symptoms we are relating to them as localized, meaning the symptoms are directly reflecting about the lung tissues. But in generalized symptoms, the symptoms can happen in any other parts of the body, whereby it could be indicating direct spread of the cancer, or it could be indicating non-metastatic extrapulmonary symptoms, blood-borne symptoms, or they can also have other physical signs and symptoms. So let's explore these symptoms differently. Like, what are these localized symptoms? What will you find in the generalized symptoms and such? So the localized symptoms, we are saying that these are symptoms that are directly relating to the lungs or directly happening in the lungs. And the main symptoms that we get here is the cough. So cough is found in 80% of the lung cancer cases and is indicative of common of the early symptoms. So sputum is purulent, and this will indicate if there is secondary infections. And then we have the second symptom where we call it the hemoptysis. And hemoptysis basically means presence of blood during cough or in the sputum. So happens in 70% of the lung cancer cases, and the client will present with repetitive episodes of scanty cough, hemoptysis, or blood. So there's blood in the sputum or the blood in the mucus when the patient coughs. This client will also present with dyspnea, and with dyspnea, this is abnormal breathing activities. It could be state of breathlessness. It could be the patient having difficulty in breathing. All this could be indicative of dyspnea. So it reflects occlusion of the lung bronchus, resulting sometimes in collapsing of the lobes of the lung, or the client could complicate with development of pleural effusion. And then we have the case of pleural chest pains. And with pleural chest pains, we reflect cases of malignant inversion of the pleura, or there could be an infection of the distal distal tumors. This could be recurrent. The pleural chest pain could be recurrent, and most of the time it fails to resolve. So I want to explain this side here where we're saying the pleural chest pain could reflect an infection that is distal to a tumor. This means when we have chest pain and we have an infection, indicating of it is that the infection that is present in this lung tumor is below the tumor. So if this tumor is in the bronchus, then the infection in this case will be directly in the lungs. We're talking about distal in relation to that tumor. So this infection mostly will be recurrent and it will fail to resolve. So you need to confirm if the pleuritic chest pain has any relationship to an infection before you assume it's just chest pain due to the malignancy. Then we have the generalized symptoms of lung cancer, and these symptoms could indicate spread to other parts of the body apart from the lungs, or it could be any other area. Then we have, in this case, dysphagia, and dysphagia means difficulty in swallowing. This is if the lung cancer has started spreading to the digestive system, affecting the esophagus and the pharynx, and therefore we're having difficulty in breathing where the client has a lot of pain and are not able to swallow. There's also presence of bone pains if the cancer starts spreading to the bones. This client will also present with headache, mental changes, and some neurological changes like paralysis or lack of sensation. When this happens, then you can say this tumor is starting to spread to the brain or to the nervous systems. We can also have abdominal pains that is indicative of spread to the abdominal areas or even digestive systems. In the elevated liver function test, issuing cases like jaundice. So with the liver function test altered, then you can say that there is a spread to the liver. But when there's a spread to the liver, this tells you that the client chances will start showing new signs of jaundice. And this could show you that the liver has been affected and it's also deteriorating. There's cases of voice hoarseness, and with voice hoarseness, now our lung cancer is in the larynx and it's affecting the voice cords, and the sore throat is now also having an issue. So you're not able to process the words. The other bit is in the GIT, where it has spread to the GIT disturbance. You start seeing signs of anorexia, cachexia, jaundice, hepatomegaly. These are cases whereby the system basically is affecting the GIT related areas. Like anorexia, where client has feelings of of, of, um, of nausea and they wish to vomit together with cachexias. Jaundice also brings similar signs of anorexia, but this basically shows you there's an involvement with the digestive systems. We also have weight loss. Because of the cancer spread, the nutritional status of the patient may be altered, where this gland is not able to absorb digestive materials or digest absorptive content, digestive systems and contents. There's finger clubbing. Finger clubbing shows extreme existence of lack of oxygen and excess carbon dioxide in the body, and this patient will show you clubbed fingers. Wheezes and stridors in this client shows you that there's an obstruction that is happening and the airways are being obstructed or blocked. There's dullness on percussion, meaning the sounds produced when you tap on the chest is not okay. There's a tumor that is increasing in size and it is blocking the airways. Then we have absent lung sounds. This is cases whereby when you're sculptating, there are no lung sounds that you're able to hear. And this indicates to you that either the lobes have collapsed or the lung cancer is growing and becoming big tumors that are now blocking the air entry to the lobes. So with the existence of these symptoms of lung cancer, the symptoms can therefore be late, the symptoms can be early, and the symptoms can also be late. So early signs, these are symptoms that will indicate to you the progress of the cancer and how far it has been. And this will include cough, dyspnea, hemoptysis, chest and shoulder pains, recurrent temperatures, and recurring respiratory infections. When you see this in a client, this indicates to you that the lung cancer has begun and it's in early stages, or these are part of our early signs. In cases where we have late signs, this indicates to you that the cancer has started to spread and it's involving itself with other parts of the body apart from the lung. So this can include bone pain, spinal cord compressions, chest pains or tightness, and also dysphagia. Other late signs includes the head and neck edema, blurred vision and headaches, weakness, anorexia, weight loss, cachexia, pleural effusion, and even the liver spread. So let's explore on the diagnostic test for the lung cancer, or how do we diagnose the lung cancer. So we can use different methods, but I'll just mention the common ones. One of it is chest x-ray. So chest x-ray provides for us the first evidence of lung cancer. It's the main one used when you want to screen and find diagnosis for the lung cancer. Then we have the CT scans, which the computed tomography scans. These ones, they help not only to diagnose, but they also help in evaluating and localize the tumor in the lung parenchyma and pleurals. Basically, this means it will help you locate where the tumor is found or where the tumor is located, evaluate it for you in terms of size, the spread out, and how basically that tumor looks like. Then we have the sputum cytologies. Mostly preferred that if you're collecting a sputum sample for analysis, you're advised you collect them in the morning, because this will give you like a more concentrated sputum content that can easily be detected and explode. So you can collect it in the morning and it will easily help you detect any malignant cancer cells that are present for the lungs. Then the other bit is MRIs, or magnetic resonance tests, and these are important for visualization of tumors. This is now where you want to see where the tumor is, how far it has affected the place, and this simply allows you to visualize and diagnose the tumor further. Then you have bronchoscopy. With bronchoscopy, we are also able to visualize and obtain even biopsy samples for further analysis. We can also go ahead with fine needle aspirations. So fine needle aspirations, this one works closely when you want to do biopsies, and we are able to obtain tissue biopsy for cytological examination of the client to determine the tumor cells or to determine the malignant cells from our client. And then we have mediastinoscopy. This is visualization of the tumor. And this is in case you're worried that there's an involvement in the mediastinum, then you can go ahead and participate in mediastinoscopy, sorry. And then we have laboratory tests that can be used also for diagnosis of lung cancer. So this includes blood tests, biopsies, and tuberculin test. So blood test here, you can focus more on complete blood count. And with complete blood count, you want to check the red blood cells, white blood cells, and the platelet levels. And most of the time with the lung cancers, there's an decrease in most of these. But you'll find for the case of red blood cells, because of the issue with cancer cells, they tend to reduce, and our client presents with anemia. While on the white blood cell levels, there's an increase in the white blood cell levels to indicate that the patient has a compromised state of safety, and therefore we have an increase in the white blood cells to assist with protection and promotion of safety and immunity. The other bit is platelets. So with platelets, they also reduce during lung cancer cases. And so when you check all this test, they're simply there to help you determine the functioning of our bone marrows and other organs, and to also rule out metastasis to the blood or blood-borne aspects. We have UECs. So UECs assist or they help assess the functioning of the liver and the functioning of the kidneys. So this means you want to evaluate electrolytes, that is urea electrolytes and creatinines levels. So with this in mind, these changes of the UECs basically indicates to you how the liver is working. For example, if you look at urea or you look at the electrolytes levels, you're able to tell if the liver is working well or not. Biopsy, on the other side, these ones you take a sample of the tissue, the lung tumor, and it's able to be determined if the tumor is cancerous or not. So it will help check the various types of cancers, and it can give us the cancer grading and staging. And under the tuberculin test, we are able to rule out that if TB is one of the cause of the symptoms or it's one of the cause of the manifestations that we are seeing in our patients. So thank you for being with me to the end. Kindly remember to share, subscribe, and also comment on the content. And don't forget to come back for the next lesson. Bye-bye.